Welcome everyone to the final keynote of the day, not the end of the conference at all, but our next live keynote. Excited to bring us all together to really get into the discussion around mental and behavioral health and how it brings together a critical and sometimes underappreciated or even overlooked, hopefully not, part of how we create aspirational healthcare. We all know that this is an area where there is a lot of challenge within the traditional system, and the need for laws to come into place to look at mental health parity have been a welcome addition to help us really turn a spotlight on this. And now we're going to be looking at how it impacts all of us. As a quick note of housekeeping, immediately after this, we go into the discussion room. So those are topic by topic. Everyone choose the area of impact and of interest, and to enter into those chat groups in order to connect with more peers and others. And with that, I'll turn over the time to Daryl to take us into the following session.
Great. Thanks, Lee. Well, it's my pleasure to be with you and to be with you here with a team of individuals that for the last 20 plus years or so have been involved in offering an aspirational mental health solution. I have with me, so I'm Daryl Moon, CEO of Orion. We've also got Jenny Gray, training manager for Orion, a health coach, Brent Hale, co-founder of Blomquist Health Solutions, Tina Halliday with Huntsman Mental Health Institute, and Melody Richards, who has been the senior HR director for a large gas company called Questar. So we're going to each take a few minutes and kind of share our part in this aspirational mental health and the lessons that we've learned by doing this for 20 years, where the design of the program was around, you don't make profits by increasing your price, you make profits by keeping everybody healthy. So the financial arrangement has been aligned to keep people healthy rather than just increase the price. And probably the most important thing that we've learned by doing this has been the importance of early intervention. You know, the saddest thing there is about mental health is that people wait 10 years on average before they reach out for help, and almost 60% of people never reach out for help. That's a huge black box of people that aren't getting any help and aren't reaching out. It's one thing to provide a really great service when people reach out. I loved April Kyle's story this morning about her young son who says, can we talk to the behavioral health consultant when we get to the office today? I really want to talk about the pull-ups. That's an amazing story of someone who at a very young age, there's not a stigma and they're addressing things early. Well, same thing needs to apply across the board. So one of the things that we've been doing in order to try to get upstream that I'll share with you real quickly is a proactive non-mental health survey with a proactive non-mental health person to address things early. So by using a pulse survey, which is really nothing but a survey that's texted out that can take no more than 10 seconds to complete, people are able to track how they're doing in each of the 8 categories of well-being, which then allows them to monitor over time, kind of like a Fitbit or a Garmin or an Apple Watch monitors your steps. They're able to monitor how they're doing in each of the 8 categories of well-being, like social well-being and environmental, intellectual, financial, physical, nutritional, social, and emotional. Well, what that allows us to do is to identify people who are beginning to struggle in any area of well-being early on and have a health coach. There's no stigma associated with a health coach. Reach out, show compassion, and begin to address and work with that person to address things early. And then as necessary, be the catalyst to help those people get in to see other levels of care. So with that, I'm going to turn things over to Jennifer and let her talk about the role that coaches play in this upstream idea of managing emotional well-being.
Daryl, I completely agree with what you were saying, and going off of that, there can be a really strong stigma barrier of mental health particularly, and sometimes using non-mental health labeled strategies are the best way to do that. You were mentioning a 10 question pulse survey that can actually be monitored by coaches, and so when you have a coach that's monitoring a person's responses and feedback, they can be the ones that proactively reach out and do check-ins and see really how they're doing, just engage them and check in with them and see what kind of support and resources that they really need. And the one of the benefits of working, I think the greatest benefit of working with a coach is that coaches are really focused on emphasizing rapport and relationships. They want to create a strong foundation of trust. So if there is ever a problem, or if there is ever a dip in any of their aspects of wellness, they feel very comfortable talking with their coach. It's not just, some random person that they're being asked to be vulnerable and share their personal information with. It's someone that they know is going to be empathetic and compassionate and really listen to them and be an active listener, and that would never judge them for perceived shortcomings or failures, that they feel very safe with, and that creates and facilitates a really safe space for them to explore and discover and ask themselves their own questions. And so coaches really can play an important role as a catalyst to move people. You mentioned 60% of the population needing health specialists that aren't getting it. Health coaches can play that role as a catalyst in connecting them to care, because they have that trusting relationship with their coach, and they're going to listen to their coach when they tell them there's additional resources and strategies that are available to you that I can't give you, but I can connect you with people who can. And I can connect you with resources that can support your ultimate vision of wellness. And that's really only able to be done because the coach has spent so much time fostering that relationship and emphasizing that level of empathy with them. And coaches are able to assess the strengths that participants already have and emphasize those strengths and help them identify barriers that are holding them back and help them create creative solutions that are individualized to them and help them overcome those hurdles. And there are times that those participants, we call them participants. I realize I'm falling into Oriant jargon. Participants, patients, members, whatever everybody calls them. When they do run into a space where it goes beyond the health coach's scope of practice, there's that really trusting relationship of when the coach says, hey, I think you would benefit from this additional resources for X, Y, and Z. How do you feel about that? Like, let's get your understanding about that. Okay, here's why I think this would be beneficial for you. Is it okay if I share some of these things, respecting their autonomy as you request permission to share, and then eliciting back to them saying, okay, from what I just shared, what is your understanding of that? How do you feel about what I just shared? Would it be okay if I connected you to this source, if I gave you their contact information? So it really is, health coaching is a fantastic underutilized resource that doesn't really have a stigma about it, but can play a really critical role in connecting people who need it to more specialized care.
Nice. Thank you, Jenny. Brent, would you like to talk about the role that your organization has played in this team?
Sure, yeah. Blomquist-Hale Consulting, or Blomquist-Hale Solutions, is the name of our organization. We were selected by the University of Utah to play a role as the front end of a very preventative population management type of a full spectrum behavioral healthcare treatment system that we developed and had a lot of success with. What we found was that that by doing the things that Blomquist-Hale has been practicing over the last 30 years, we were able to significantly increase the number of people who actually access care in the preventative, solution-focused, problem resolution level of care. We generally will have somewhere between 300% and 400% higher utilization than might be typical for a more normal EAP. And so there's some things that we do to make that happen. Obviously, we set it up so when people access our level of care, it's free free of charge. There's no co-pays. There's no out-of-pocket costs. EAPs fit underneath the parity legislation in such a way so that they do not have to work all the way through the high deductibles in order to access care. We very specifically reduce stigma by addressing life issues and life problems and communicating clearly that people don't have to have a mental health diagnosis in order to receive professional counseling. And another thing that we've discovered that is very, very important is that when people call and access this level of care, it has to be sufficient to really help most of the problems. It can't just be an assessment and referral service. It needs to be something where people actually go to work and they resolve issues and difficulties. So we make our system sufficient to handle about 80 to 85% of the problems or the individuals that access us, meaning that we only need to refer on to more intensive levels of care, about 10 to 15% of the population that comes in to see us. In order to make that happen, we train our therapists in a clinical modality we call solution-focused brief therapy, which is a very active form of therapy that engages individuals in a system of care designed to help them to define the problem in such a way so that they're comfortable with it, they're focused on what they develop hope that they can achieve, and that requires active steps on their part. The key to making this happen is to build a very caring relationship up front. So we train our therapists in some very specific interventions to make that happen very quickly. And what we find by doing all of these things is that we're able to achieve wonderful clinical outcomes in far fewer sessions, which really does help. Another thing that we found is really important is that the very first reach out, where somebody is saying, you know what, I think I need some help, that reach out needs to be a secure attachment. That at that point in time, they are securely connected to a therapist who's going to help them. That they walk away from that very first phone call, either with a conversation with a therapist who begins the process, or at the very least with an appointment, a specific appointment scheduled. We found that if what happens is that we give the people a list of 3 or 4 clinicians that they could call, that they're authorized to get help from, that we'll pay for, that fewer than 50% of the people make the second phone call. And so the key is to make sure when anybody finally reaches out that we connect with them and we keep them in the kind of care that they need until they successfully resolve the problem. Doing all of this requires a very robust information system, much more robust than I think most organizations would have, so that we can monitor things like the follow-up phone calls that our clinicians make to our participants to ensure that they had a successful experience and to find out if the problem is really resolved. For those who do need help beyond the solution-focused care, one of the things that we developed in this system was a warm handoff to a care manager. So that it's not just a matter of giving names and numbers, it's a matter of having a live person contact them either in the transition while they're in the session or afterwards, that then help them negotiate the behavioral healthcare system and helps them get appointments and follows up with them to make sure that a good connection takes place, because obviously a big part of the issue here is not allowing people to fall out of care prior to getting resolution. So with that being said, I'm going to turn the time over to Tina, who manages the group of care managers that make that happen.
And before Tina takes over, I'd like to encourage Brent, share just a little bit about how you partner with companies to get that high level of utilization in addition to the support that the coaches do. So getting in front of employees, training supervisors, some of the kinds of things that drive up that high utilization?
That's relationships is the key. People grow, they access care because they trust, they have hope, they know who they're going to be accessing. So one of the things that we do is we spend an inordinate amount of time reaching out to our client organizations, doing orientations, workshops, seminars, supervisory training, so that people see us, they know us. We want anyone who's listened to one of our orientations to say to themselves, if I had an issue going on in my life, I'd call those guys. They're good. And we find that really does drive utilization. Pieces of paper, emails, signs, posters, all of those help a little bit. But what we found is the personal relationships that actually take the water to the end of the row and you get high utilization.
Great. Tina, you want to talk about the role that your specialized mental health case managers play? You're on mute. Tina, you're going to need...
The standard memories of COVID, right? You're on mute. Sorry. Thank you for the intro. And I think as you're listening to each of the presenters thus far, you're probably hearing the common theme that our goal is to support, allow access for folks to get into treatment. If folks aren't getting into treatment, then their health is going to be compromised in some way or another. So with our integrated behavioral health model that Brent had talked about, from the EAP to a warm handoff to our team, our charge is to get people access in a timely, efficient manner, and also to get people connected with the right type of resource. So again, instead of giving them the 3 names and, to people who aren't even qualified to provide what someone needs, we're getting rid of the barriers, getting them to the right professional in a timely fashion. We lose a lot of folks between that handoff when they can't get in for months or weeks even. So we're working with our case managers, care coordinators, with individuals with that relationship that Brent referenced in a different format, but even our format of having somebody now that becomes their helper. Our folks are clinicians, behavioral health trained clinicians who have that insight as well to work with our folks. We have also gone to great lengths to create a panel of providers whom we know, many of which we have trained. We are a university healthcare system. We provide research training and treatment. And so many of our professionals we have as our providers are providers we very much trust because we've trained them, we know them well. And then any new providers we do bring on that may not be part of our training system, we vet very carefully. We only provide a resource to our membership through providers who have at very minimum a 2-year post-licensure experience, because we want providers who can do the job and that we feel confident can do that job for the members that we're serving. So we're looking at uniquenesses, we're looking at access. Any of you out there, I'm sure, can relate to the lack of resource really across our country in terms of psychiatric care. Well, our psychiatrists have openings and we often can get folks in within the week, and not necessarily even under a totally urgent crisis, but to get people into their medication management. So whether that's individual therapy, whether that's psychiatry, whether that's group therapy, or higher levels of care of IOP, PHP, in-home family care, or inpatient care. So again, we're looking at the range and the uniqueness of the individual. The one thing I wanted to talk about that I think is also a uniqueness to us, other than knowing our providers and our providers knowing us, and we have a collegial relationship with them rather than what I would say is a negative relationship typically with insurance companies in general. But these are our colleagues. We're working together for the best interests of our member, but also the fact that we're ongoing working with our providers. So when we have some of our outliers of our severely mentally ill population, we're putting our heads together. We as a team historically have taken a multidisciplinary team approach to review cases on occasion where we feel like this individual isn't getting their needs met. We want to avoid that revolving door of an inpatient setting, for example, which isn't the best care for the patient. It's hard on everybody. I don't think it's a good investment of resource either, whether that's financial resource or emotional, mental, physical resource of an individual in that situation. So we have certainly as a team taken our variety of colleagues, some of us in this meeting today, and sat down and looked at a case and really strategized about what are all the lengths and types and levels of care that this individual really needs under this unique circumstance, and found some great outcomes with that, again, for our real high utilizers and very mentally ill population. So we're serving a range of people with a range of issues and providing a trusting relationship to get them to the right care in an efficient, effective manner so that they'll stay in care and we don't lose them. They don't drop out of care. And the continuity of care is so significant to getting to good health care again. What did I leave out, Daryl? Anything?
You're on mute.
Yep, I did the same thing. No, it sounds good. Thank you. So Melody, you've had the opportunity to experience this aspirational mental health solution with your thousands of employees over the years. Share with us, share with the audience what your experience has been.
Well, as the manager of benefits at Questar, we were responsible for the mental health of all of the, our 2,500 employees and 1,500 retirees. And when we initially started with Blomquist Hale, one of the things that drew us to them was the fact that there was a difference in approach, not just here you have three sessions that you can get, and if it doesn't work, then you're on your own. But it was a short-term solution-based approach that we really appreciated and that our employees really liked as well. They liked the fact that if the counselor that they were working with felt like that they needed additional help, that they could go ahead and do that up to a certain limit. And then we also, were able to build that trust with employees and their dependents because of the relationship that we have had with Blomquist Hale. And that, as Brent said, I think that relationship was key to the success that we had with our members. We had lots of employee stories that came out of the successes that they were receiving with their care that they got through Blomquist Hale and the University of Utah. And we were able to spotlight those in some of our employee meetings and in our employee communications, and so that others could understand the benefits of using the services that were provided to them. One of the things that I think was so key in the approach that was taken with our employees was also what Tina mentioned, that it was a team approach, and that we looked at each individual personally to say, what do they need? What is their needs? And how can we help them? Whether it was through the EAP, whether it was through more intensive treatment through the University of Utah, that team looked at each case individually to make sure that they were receiving the care that they need. And I had lots of employees and lots of dependents who reached out to me as the manager of benefits to express their gratitude for the help that they received, because they would not have been able to get better or continue on as a result of that if they hadn't had that team approach. And as an employer, it was important for us to make sure that our employees and our dependents were receiving the care that they need, but also that our costs were being controlled. And one of the things that we found is that by going through Blomquist Hale, that, we could get most of our care through them, and employees didn't have to pay anything. And it was at a lower cost to the employer as well. But also, even those that had to be referred out to more intensive care, there was a lot of cohesiveness in that, and that increased the benefits of being able to control those costs. As Tina said, their counselors were trained to address the situation, and it helped us to be able to control costs over a long period of time. We saw our mental health costs be significantly lower than what we saw other people's costs being in the industry. And we do truly believe that it was a result of the relationship that we built with both Blomquist Hale and the University of Utah and Orion to be able to focus on the needs of our employees and their dependents, and provide them the care that they needed in a timely and economic manner.
It up for questions. Thank you very much. Appreciate that. We're going to open it up for questions now. And if you'd like to ask any of the team questions, please just send those through the chat. And while we're waiting on that, let me just ask Brent if he would talk a little bit about this no session limit design that's very unique in the market that Blomquist Health uses to offer employee assistance. And how do you then limit it in order to stay within the EAP parameters? Talk a little bit about the no session limit idea.
Yeah, that's an idea that we experimented with a number of years ago and have figured out a way to actually make it work. What we found was that previously there had been a artificial limit set, like 5 sessions or 7 sessions, even 10 sessions, so that when you hit that limit, you were done. That's all the benefit that was available to you. What we found was that by training our therapists to use the more powerful solution-focused approaches, that we could base it on average number of sessions instead of what the outliers were, which allowed us then to be able to provide more intensive, longer-term care to individuals who would benefit from it, and we could achieve good clinical outcomes within this environment by providing additional sessions. So we advertise our services as not having a specific limit to the number of sessions. Now, that doesn't mean that we provide long-term ongoing therapy for folks. What that means is that if the problem type appropriately needs to be referred into a level of care that needs more developmental, long-term counseling, that what we're going to do is we're going to work with a warm handoff to Tina's team to get them right there to initially to begin with. But what we find is that because we're carefully monitoring all of those averages and we're making sure that we're not overloading the therapist by getting the right number of people into each caseload based on the acuity of the current cases, that what we're able to do is to make that system work.
Nice. Tina, one of the things that's been remarkable over the years that I have appreciated is the fact that instead of organizing a treatment plan or coming up with, services for the person, it hasn't been based within a parameter of benefit design. It doesn't matter what the benefits look like. What matters is what the person needs. You want to talk a little bit about how this has been very much managed outside of a parameter of a benefit structure?
Yeah, I mean, I think that's one of the uniquenesses certainly of our programming is looking at the individual. You can have 10 individuals with the same diagnosis, but their needs can all vary and what they may have the best chance of and success becoming healthy and stable by implementing. So I think very much the uniqueness of our program is the individuality of the program and looking at needs and the creativity and thinking outside the box of resources and wraparound services and all in lots of different elements of an individual. I remember one of our very high utilizers, a very significantly mentally ill person, having multiple wraparound services. And we incorporated a wellness coach. We had medical folks involved. We had several professionals in the mental health realm involved. And on an outpatient basis, this individual had been hospitalized numerous times. On an outpatient basis with this wraparound team, this individual was able to stabilize and function. And, the ripple effect of that for Melody, this is one of her members, is that the employee, which was the spouse, was able to be at work and be a functioning entity for the company that they're working for because that family member was helped and was able to stabilize. It was just it's a fantastic resource to look at when you can think outside the box. And really, I guess even without the benefit design that you're bringing up, Daryl, we were able to maintain cost because now this person isn't needlessly going inpatient over and over again, utilizing extra dollars not in an efficient manner, just because that was the safety mechanism we had to get caught up in. When it moved to this well-functioning wraparound service model, it was an investment that was successful and less costly in the end. So in lots of avenues, it's very helpful to have that flexibility.
Tina, you mentioned in your presentation the fact that it's a partnership with the providers. Talk just a little bit about how having a primary behavioral health level through the very generous employee assistance program, so that really the people who need to go into secondary care were clearly in need of that level of care, how that created no adversarial relation. In fact, it was very much a partnership with the provider network, and you weren't having to look over their shoulder, cross T's, dot I's, worry about whether there was true documentation. Talk a little bit about how that played into providing optimal care and therapy for the patients.
Well, I think our focus then was about care, Daryl. It wasn't about numbers. It wasn't about visits. It didn't become adversarial. So we ended up working as a team for the benefit of the member, which offered us the opportunity to continue with other options. Hey, maybe we need to bring a health coach in with this member to assist with what you're telling us is happening in therapy, and how do we support the therapist on a trajectory toward health and stability. So, I mean, it was an open conversation then that we worked together. I think adversarial is my word when I think of over the past 40 years. Of course, I'm much younger than dealing with mental health for that long, 30 years. Of seeing really an adversarial approach to this and really getting in the way of getting people what they need.
Nice. Jenny, you talked a little bit about the relationship between a coach and a participant. Talk about how, as a coach, because of that trusting relationship, often emotional issues come up that may otherwise they have kept to themselves and maybe never brought up with anybody.
Absolutely. Well, one of the foundational style of communication that our coaches use is motivational interviewing. And one of the foundational principles of motivational interviewing is expressing empathy and empathetic listening. And it's surprisingly not something that a lot of people are used to. They're not used to speaking and having someone very engaged in what they are saying and empathetic to what they are saying. And because of that, and non-judgmental for what they are saying. And because of that, absolutely, it can bring up a lot of vulnerability and a lot of emotional outpouring, because it's the first time that they've had this safe space that's free of judgment, that they feel comfortable to share those feelings and to explore those feelings and to dive deeper into those feelings. And that really comes just from the basic foundation of just being listened to.
Nice. Melody, in terms of the alignment, we talked a lot during this conference about the alignment between the buyer and the seller. In this case, because this team took on the financial risk, talk a little bit about how that felt as the customer buyer in terms of alignment, and that we were working on the same page for the same end.
Well, I think it meant a lot as an employer because, we were able to budget our costs. We knew exactly what our costs were going to be because it was a partnership between as a self-funded organization, our mental health was self-funded. And so we knew, sort of what to expect, but we also knew that, if an outlier came along and we needed to go outside of the box, that there was freedom to be able to do that. And because of the fact that we were able to control costs through the EAP as much as we were, then we could put those additional dollars to services that were needed if the need arose. So I think from a perspective of an employer, we were able to maintain our costs at a lower cost and still be able to provide an effective level of care for our members.
So maybe if you wouldn't mind, Melody, talk a little bit about this whole concept of aspirational healthcare, not just within the realm of mental health, but this aspect of really building an entire healthcare system around the customer. And as a customer buyer of healthcare, representing an employer, how does that resonate with you in terms of offering something that's going to attract and retain top talent?
Well, I think it's critical, especially with the healthcare market the way it is right now, and the whole healthcare industry the way it is right now. Costs are significantly increasing, not only from the mental health side point, but from the medical side point. And so employers are needing to find ways to control those costs, but be able to continue to provide those benefits to their employees such that they can attract and retain those employees that they want to have. If you can't control your costs, if you cannot keep those at a reasonable level, employers, then the first thing they do is cut benefits. And when you cut benefits, employers are not happy. They're going to go to another company where they can get the benefits. So it is in both the employer's perspective beneficial and in the employee's perspective if we can help control those costs by utilizing the services that are identified in an aspirational type of health scenario where you're looking at the individual as a single source and not as a group, and you're providing them with the benefits that they need early on to help control those costs, then you can keep those costs down so that you can keep continuing to offer benefits to your employees that they want.
Nice. In the last couple of minutes that we have, Brent, do you want to start off by just a final minute or two of summary, and then we'll go around and ask everybody to do the same thing?
Sure, happy to do that. Yeah, it's been a very interesting and rewarding experience over the last number of years to be attempting to create an aspirational mental health system that aligns all of the incentives and helps more people. It helps them in a more preventative way. And, you know, I sit here thinking of the individuals, you know, the bottom line is where it impacts people. And there's just so many folks that got help that otherwise would not have gotten help. And are living much more happy, productive lives, and families are working better together, marriages are saved, and employees are taking care of aged parents and not feeling overwhelmed because they were tied in with kind of supportive resources that made it possible for them to do that. So it just makes sense to me that you don't park an ambulance at the bottom of the cliff, but you put a fence at the top, and then you have somebody there that you trust to be saying to you, hey, well, let me help you with that. Let me help you figure out how to make that work. And people respond. They really do go to work when they're given the opportunity to do so in a focused way.
Nice. Jenny, any last minute words?
Sure, thank you. So I started my college career as a pre-medical route, and the more that I became involved in that field, the less I wanted to do with it. And I became really interested, and I was introduced to the field of wellness and of preventative behavior change, and I fell in love with it. Like Brent was saying, it just made so much sense. Put a fence at the top of the cliff instead of an ambulance at the bottom. And as a health coach, I just want to say health coaches are such a valuable part of any medical team. Everybody plays a role. So often as health coaches, we hear, well, I talk to my doctor. I go see my doctor about that. Yeah, but your doctor has 5-10 minutes tops to talk to you about this thing, and it may or may not address your concerns, and it will more than likely end up involving some sort of prescription. And health coaches are able to make those connections, to really spend the time to understand what is important to you, what you want your vision of health, what you want your life to look like, and to help develop strategies and behavior changes that are going to get you there. And so it's great to just be part of this conference and to see health coaching as part of the overall big picture and team as part of aspirational healthcare. So thank you, Daryl.
Thank you. Melody, any last minute words?
You know, I want to just echo what everyone has said as to how important it is for employers and providers to work together to come to a solution that is focused on the employee, focused on their needs, and getting them the needs that getting them the services that they need to help correct their problem, whether it be a mental health problem, whether it be a medical problem, whatever. That is what will help to control costs, to be able to keep employees happy, and to be able to maintain our workforces that we need so that they can be at work when they are there, but they also feel comfortable knowing that they're getting the care that they need outside of work as well. So I think it's really critical that employers and providers work together to try and create this kind of an atmosphere for employees to be able to receive that care.
Nice. Thank you. Thank you, all of you. Brent, Tina, Jenny, Melody. What we're going to now do is transition into the breakout discussion groups. We'll be holding those today, right now. We'll be starting those up in a couple minutes. We would encourage you to participate. We're really hoping that that's where some of the real meat and potatoes of this conference will exist, is when people together just talk about how do we transition from a deficit-based healthcare system that's often expensive and dysfunctional to an aspirational healthcare system like we've heard about, especially with the NUCA system being kind of the example to put on the pedestal. We're going to hold those discussion groups now after this meeting, and then again tomorrow morning before the conference starts, and again at the end of the day tomorrow. So please participate in those, join in. It'll be an open forum where people can share their thoughts, go on camera, go on microphone, and participate in an open discussion. So with that, we will officially conclude this part of the conference and invite you to click over to the discussion groups. Thanks and have a great day.
Thank you.